everyone. We're so excited that you're here for the next edition of the IACH for Pharmacists. We are really excited about today's topic. We're going to be discussing the dosing of antineoplastic agents in patients with obesity undergoing preparative regimens for hematopoietic stem cell transplantation with Dr. Joe Bubalo. Dr. Bubalo is an assistant professor of medicine and a clinical pharmacy specialist in oncology and transplant at Oregon Health Science University, where he has been practicing in this area for over 30 years. He's an excellent person to talk to us on this topic. He has a lot of experience here, has presented on it a few times, and then also importantly helped author the position statement from the ASTCT Practice Guidelines Committee regarding the use of these agents and how to dose these chemotherapy agents in patients with obesity. So really excited to have him here with us today and looking forward to a great presentation. So thank you very much, and we'll let you take it away, Dr. Bubalo.
Thank you, Dr. Gatwood, and welcome everybody today. It's my pleasure to be talking about the dosing of in obese patients, and I'm going to just move forward into the objectives. We're really going to go through current BMI demographics and their implications for stem cell transplant. We'll talk about how and why we developed the guidelines, and then really going to spend most of my time on looking at additional literature that has occurred since that time. The current state of BMI in world populations, when we look at the USA, we're up to almost 40% rate of obese individuals, with actually on the other side about 1% are underweight. And if we then move into kind of world trends, we see that as for the world, developed nations in general have much higher rates of obesity. And importantly, if you look at this timeline, around 1990 is when stem cell transplant really came into its own, and the use of it started to pick up as the processes around it were solidified and made more universal. And then through the 2000s, the first decade, it became a standard of care and a thing that was much more common actually throughout the world. And if we notice during that time, there's a steady trend, upward trend in obesity in most of the world countries, whether they be really well-off countries or those that don't have the similar amounts of resources. So whether this is something that you're dealing with now or something that you'll deal with in the future, I think this is going to be an ongoing topic of care in stem cell transplant. If we look at the effects of BMI on stem cell transplant outcomes, and this is referring to allo transplants in this review. This is 2,500 adults, median age around 50, and varied malignant diseases. About half of them were myeloablative, and about half were reduced intensity, with really majority stem cells, peripheral stem cells for grafts. Just by definition in this review, these are actually the standard BMI definitions. Less than 18.5 is an underweight individual, 18.5 to 24.9 is normal, over 25 to under 30 is overweight, 30 to under 35 is obese, and then over 35 is considered very obese. And I'll have some variations on this, but this is really what you're going to see through most of the talks, though many centers have their own definitions for obesity. When they dose off of total body weight, they looked at, and we found that dosed off of, and you're going to see these are kind of universal definitions I'm going to use through our abbreviations I'm going to use throughout the presentation. But in general, you'll see that until around 120% ideal body weight, which is what most centers look at, over 120% is considered possibly obese or certainly overweight. And then afterwards, they dosed on 25% adjusted body weight, and I'll call that ABW 25, which is ideal body weight plus 25% of the difference between total and ideal body weight. 1% of this population was underweight, around a third was normal, another little over a third was overweight, about 16% were obese, and about 10% were very obese, so the over 35 BMI. Interestingly enough, the underweight, that 1%, had the highest rate of overall mortality, non-relapse mortality and day 100 mortality. However, they looked and they saw that overweight had the highest relapse rates. This continues to be a concern when we think about are we dosing these individuals with enough chemotherapy? When we look at the different combinations, a myeloablative individual with TBI as part of their PrEP regimen had the highest non-relapse mortality. And then if you look at by group, underweight was greater than the very obese, which was greater than the overweight. And these were significantly different when compared to the normal BMI. A myeloablative without TBI, overweight was actually protective, and very obese without TBI had the worst non-relapse mortality compared to the normal BMI. Reduced intensity, only underweight was significantly different in non-relapse mortality from the normal group. In overall, BMI was not related to relapse despite in a statistically significant way, despite the concerns. And the other question that sometimes come up is should a individual try to lose some weight prior to stem cell transplant? And there's actually evidence that this is possibly going to harm that person if they have a significant weight loss right prior to their stem cell transplant procedure. So as I move into this topic, really same things to think about as you're looking at, an obese individual would be, is this an allogeneic versus an autologous transplant? Or is our goal tumor ablation versus myeloablation versus immune suppression? The actual PrEP regimen, is it going to be ablative, reduced intensity, or non-myeloablative? Is there anything unique about their race or ethnicity? What is the combination of agents? And that last paper makes you wonder, is a TBI containing regimen one that really needs a little more thought? And then in general, these all assume normal organ function. There are actually currently no papers, including the ASTCT guideline that we produced, that look at organ dysfunction and an obese individual. Just a brief review of on conditioning therapy. The goals here are generally going to be to eliminate the host's bone marrow and maybe their immune system if we're going for an allo. We certainly want to prevent rejection of a graft if it is a allogeneic transplant. And then we want to make sure we reduce our residual tumor, whether it be autologous or allogeneic, in the malignant setting. In the non-malignant setting, we're really just immune suppressing and preventing rejection of the graft. When we think about a chemotherapy agent that is a good conditioning agent, we want hematologic dose-limiting toxicity. This allows us, since we're going to replace the marrow either with an autologous boost or an allogeneic graft, the hematologic toxicity is really not relevant here. Want a steep dose response curve, is whether we're affecting the immune system or the malignant cells. We want to make sure we have activity against the malignant cells, so whatever that disease is. And then any modulation of the immune system that comes along with that is certainly a bonus. Just when we think about intensity, the greater the disparity, looking up the left side of this graph, we need more immune suppression. If we look towards the right side of the graph, those are the group that have much more aggressive malignancies. So if you have a great high disparity and an aggressive malignancy, that's where we think about an ablative PrEP regimen. So looking to the far upper right, TBI-Psi, Abu-Psi would be examples of that. As we have a less aggressive malignancy or a decreased need for immune suppression, we'll go to less aggressive regimens, and you're going to see us use reduced intensity or non-myeloablative regimens. I know this is a fairly standard graph, so I'm actually going to move on. When we think about the agents used and the doses, these are often significantly different than what you'll see in standard chemotherapy. So it's an important part as a pharmacist, to remember all your safety guidance when checking a chemotherapy PrEP regimen versus a regimen for standard chemotherapy. There really should be a different set of attention to make sure that everything is still correct. So why an obesity guideline? This was back in the early, actually this beginning of the second decade of the 2000s. The prevalence of obesity in the US continues to rise and was certainly significant then in the upper 30s%. We wanted to make sure that this wasn't going to affect our ability to deliver therapy. We wanted to understand whether there was a significant contribution to morbidity. Risk factors that had already been noted were things like poor wound healing, increased comorbid conditions, and post-operative infections, depending on what the patient needed performed. And if you think about the non-cancer deaths and cancer survivors, over half of those are cardiovascularly related, and diabetes is certainly a additional increase in mortality. So as we had higher rates of obesity and comorbidities that come along with it, what was this going to do to our ability to transplant these individuals if needed? When we think about defining obesity in a pediatric setting, and I am not a pediatric specialist, so if I say something wrong here, feel free to throw it in the chat. But in the little ones, we're really looking at someone who is above the 95th percentile, so these less than 2 years old. 2 to 19, so into the adolescent age, you're still looking at 95th percentile for age and gender, and overweight is above the 85th to the 95th percentile. As we move into adults, overweight is above 25, but less than 30. Obesity considerations start at a 30 a BMI, grade 1 being 30 to 34, grade 2 being 35 to 39, and grade 3 being greater than 40, greater than or equal to 40. So when we think about the goals of conditioning chemotherapy, which we kind of just reviewed, that immune suppression, the reduction in tumor burden, and when we looked at overall survival, we even back when we created the guideline, we were seeing similar overall survival between normal and obese, normal weight and obese individuals. There was, however, higher non-relapse mortalities rates, somewhere around 10% or more, but lower rates of relapse in the obese, which kind of goes against the need to worry about whether we're dosing too light. There's certainly a potential for increased and potentially decreased peri-transplant morbidity. We saw increased infections, increased drug-specific toxicity as we're trying to figure out how to dose, and longer lengths of stays in some individuals. However, when we looked at melphalan, we saw that really large people had less mucositis, and often, depending on the agent, and this happened with multiple agents, we saw decreased times to engraftment. So not as much damage possibly done to the marrow space. When we think about the measurements of the patient, once again, we're thinking about ideal body weight versus total body weight, and then some adjustment of that, whether it be 25%, 40%, 50%, or other. And then we looked at the actual BSA formulas as well, and whether they should be based on total, ideal, or an adjusted weight. And in general, there is no preferred BSA formula. You would use one that's correct for the age of the individual. One ideal body weight probably needs just a little bit historical context. These come from actuarial tables when the insurance industry looks at someone and tries to decide how long they're going to live and how they want to sell that person life insurance. While there are multiple out there, the Divine method, which was created in 1974, being the first, and the one that has persisted despite others that came along after that maybe were a little more or less specific in certain ways. But generally for men, it's going to be 50. For somebody who's 5 feet tall, it would be 50 kilos. If you're over 5 feet, any inch above 5 feet is an extra 2.3 kilos added onto that to equate the ideal body weight. Females, the same adjustment for height over 5 feet, but they start at 45.5 kilos. So the guideline, which came out in 2014 after an extensive review of the literature that was available at that time, per agent was put out, and this is one of the tables. And I'm going to most of the things actually are BSA based on total body weight. A few difference. Alemtuzumab is a flat dosed. Busulfan starts at adjusted body weight 25% or ABW 25 and we recommend actually PK monitoring for everybody who's going to be in the ablative range. In the non-ablative range, we're not sure actually that busulfan monitoring is necessary. Cyclophosphamide was probably the one that the way it was written in the table has been most confusing. But when you're looking at a 200 per kilo regimen, so usually 50 per kilo per day for 4 days, that should always be on the lesser of either total or ideal body weight. When we look at Cy 120, it should be dosed on ideal body weights in adults. And there were some literature that supported a little higher dose in pediatrics, where up until 120% ideal body weight, that kind of obese um, uh, setting that some centers use would be total body weight, and then above that, an adjusted body weight 25%. In the actual paper, there was some confusion as whether that adjusted body weight 25% was meant for adults, and it was not. It was meant for pediatrics. Topicide does have an adjusted body weight for mg per kg dosing, but BSA was on total body weight based BSA. And then Thiotepa had a adjusted body weight for BSA. And actually, I think I don't know, carmustine did also had adjusted. Carmustine being 25%, and Thiotepa was 40%. So what's new since the guideline? We look at that as kind of a reset point. It was a impetus actually for many individuals to go back and look at their populations. And we had quite a number of useful articles that came out. The first and one of these looked at centers just to see what they were actually doing. So this was a group of 56 European centers. 45% of those, about 80, or 45, about 80% of those dose adjusted, and almost 20% dosed on total body weight. So the total body weight, there were 16 centers, so it's about a third of them. Ideal body weight centers were 21%. Adjusted body weight 25% was a third. Adjusted body weight 40 was about 8%, and then there are some other centers that did differently. A lot of these, 44% capped at 2 meters squared BSA, and this include 2 of the total body weight centers. 12 centers capped at some additional number that was greater than 2 meters squared. And then 36 of the centers used the same adjustant in an ablative prep that was that was used in reduced intensity, and 12 used a smaller adjustant in reduced intensity, kind of compensating for the fact it was a less aggressive regimen. So there's wide variability throughout the world, really, in how, because I think the U.S. is no less diverse in what they do at different centers. The IBMTR or CIBMTR did a retrospective review looking at autologous stem cell transplants. So this was over 500 centers, and they did a 2014 cutoff. So this would have been everybody treated before the guideline. Adults greater than equal to 18 with a BMI of greater than 30 or equal to 30. So these are by definitions obese. And they looked at myeloma and lymphoma, and they looked at the 200 per meter squared melphalan regimen in myeloma and the beam conditioning regimen in lymphomas, both Hodgkin's and non-Hodgkin. The pre-transplant total body weight, a dosing weight, and a calculated ideal body weight were used to look at the melphalan dose to see whether or not it was adjusted. If the dosing weight was less than 80% of the total body weight, it was considered adjusted. So that was how they defined those groups. And then they divided those groups into 2. If the patient dosing weight was a total body weight dose, that's considered the unadjusted group. If there were something below 80% of their total body weight, that's going to be adjusted group. The degree of adjustment, whether it was 25, 40%, 50%, was determined by looking at the total body weight versus the dosing weight. So we had myeloma, was almost 1,700 patients, just short of 800 for lymphoma. The adjusted was actually 78%, interestingly enough, in both groups, though this is just a selection by opportunity. Uh, and the cohorts were pretty well matched when we looked at them. Median dose adjustments were around 25%, so ABW 25 is the most common dose adjustment out there. Length of stay for adjusted versus unadjusted was a day less. When you actually looked at the unadjusted patients who had a longer length of stay in the myeloma population, they actually found a significant difference. So there's something that maybe was being a little more toxic there. Once again, this is a retrospective review, though. You can't really equate that to causality. In general, younger age, a high Karnofsky, greater than or equal to 90%, and a low index of comorbidities and chemosensitive disease were all independent predictors for lower mortality. Similar treatment-related mortality, treatment failure, and cause of death was seen between groups, so there wasn't any group that actually stood out that way. Things that were of lower risk were for treatment-related mortality, once again, it was younger people, high Karnofsky, and actually a myeloma diagnosis was less likely to die during transplant than a lymphoma. Treatment failure, females had higher rates. I'm sorry, the females had lower rates. These are protective factors. Once again, that high Karnofsky and chemosensitive disease. There was a time-dependent effect on the adjusted patients as far as relapse risk. They looked at a 5-month interval and an 8-month interval. And the unadjusted group in the first 5 months post-transplant, these are autos once again, and had a decreased relapse risk. And then as they got after 5 months, the adjusted and unadjusted really had the same relapse risk. So there was a kind of an early decrease in relapses with those that were dosed on total body weight. At 8 months post transplant, their relapse hazard was similar in both diseases, so lymphoma and myeloma. Greater than 8 months after transplant, relapse risk was higher in myeloma, which kind of makes sense if you think about it. We're not actually curing. This is a palliative intervention for myeloma, whereas it's a curative intervention for lymphoma. So if you're 8 months out in a lymphoma and have not relapsed, that makes sense. There was a transplant center effect that predicted for treatment-related mortality, progression-free survival, and relapse in the myeloma patients, but not lymphoma. So the more transplant a center did, they had better outcomes. And then once again, looking at the different things they looked at, really that less than 5 months is the only thing that is statistically significant that really stands out. Additional results, 2-year overall survival when you compare the adjusted versus the unadjusted. There was no significant difference in either disease. Progression-free survival, however, myeloma really approached significance. And then progression risk, once again, the adjusted versus the unadjusted early on was significantly different. Treatment-related mortality, no real difference between groups. Overall, the findings showed that the adjusted group did not have a significantly different toxicity or different overall survival from the unadjusted group. This really kind of built upon a lot of single center reports and an EBMT report that showed myeloma with similar results. This was the really large patient population, probably the largest analysis out there in autos. It was good that it had both overall and disease-specific analysis and a good representation through a BMI of up to 39. If we look at some of the things where it could be improved, there was not a overweight or a normal BMI comparator group. So these were all obese individuals. So we don't know really if it was that different than those with normal BMI or just overweight. There's no power calculation here. These are statistics of convenience. And once again, that BMI greater than 40 is underrepresented, and the greater than 50 dosing is actually completely uninformed by this study. Groups following the AST transition position paper would have been in the unadjusted group, but would have been adjusted for carmustine dosing. So this it supports as reasonable the guideline that had come out of the guideline group for ASTCT. What we couldn't look at is specific toxicities. Length of stay was a surrogate, but that's really an unclear, as you know, patient experiences do vary. If you look at the patient population by BMI, we had a pretty reasonable representation in the 30 to 34 range. So the obese, um, and then the stage 2 obesity, the population drops down, and then stage 3, which is the greater than or equal to 40, is actually quite pretty small numbers, even though we started out with all those patients. But they're really not representing the really large people very well. So in summary, this review by the CIBMTR, myeloma data supported the current guideline dosing for actual total body weight BSA. Lymphoma was not actually per guideline, but based on the melphalan adjustments, there were it was really pretty close for beam. Only carmustine was going to be adjusted based on the guideline. BMI greater than or equal to 40, still equivocal and untested by any real life report or database. We just don't have huge numbers of those really large individuals. And once again, this is a retrospective review at database level, so we couldn't look at drug specific effects. This is a pharmacist paper, to Kendall Schultes, and I throw kudos out to her for doing it. The retrospective single center review looked at myeloma patients undergoing their first autologous transplant between 2009 2012. 270 individuals, about 63% were obese. That's what was defined as greater than 120% ideal body weight, so kind of as we talked about earlier. They did have a comparator group of almost 100 people that were non-obese, and these were just less than 120% ideal. They included both 200 per meter squared and 140 per meter squared prep regimens, and the divine calculation was used for ideal body weight. If the total body weight was less than ideal, they dosed the BSA on total. It was less than 120% ideal body weight, they dosed on ideal, and if they were obese, as defined as greater than 120% ideal, they had actually a 20% body adjustment. They were well matched for baseline characteristics, including high-risk disease, primarily Caucasian, slightly more males with the median age of around 61. 94% were at that 200 per meter squared dose. Overweight were dosed per the guideline dosing. Non-overweight, 83% were on ideal body weight, and 17% were on total body weight. So even in the non-overweight, they had some variability. They looked at those that increased from a CR from a PR or a VGPR to a CR, and they found that in the overweight it went from 10 to 22%, and in the non-overweight 3% to 21%. So both groups actually had significant reduction in disease. If they looked at just VGPRs, about 26% to 30 went to 33% CRs, and in the obese population, and then there was a slight reduction actually in VGPRs in the non-obese, not significant though. No significant differences in time to engraftment or length of stay. Overall survival was actually event-free survival was slightly better in the obese population, and no significant difference in overall survival. So the highest weight here is 102 kilos. The highest BMI was 34.8. So once again, those larger people, in this case, anybody with a BMI of 35 or higher, are not represented. Why dose the non-obese on ideal body weight? It's not per guideline, but that's just probably a center variability. So this really makes you wonder, can they still actually figure out a dose-related effect in the obese cohort? That non-inferior event-free survival might have been an anomaly of the study design. There was a slightly greater number in the 140 per meter squared in the non-obese, which the authors called out in the discussion. And while greater than 120% ideal is commonly defining obese in stem cell transplant protocols, it would really be nice to equate this to BMI to get a more standardized look at things. Median dosing BSA for the obese was 1.78, which is not that obese, and 1.72, so really similar. Lower rates of high-risk cytogenetics were seen in both cohorts, and at 16 months, there was a decrease in event-free survival for high-risk individuals. So overall, good responses for this group, and a really interesting examination. We move on to a beam conditioning regimen. This is going to be lymphoma patients. Once again, these are, and all of these in this group are autologous papers, but we really don't have a great deal of data looking at allogeneic transplant. This is 91 patients between 2013 and 2015. They were dosed on a total body weight BSA. Obesity was greater than 125% ideal body weight by the Divine formula. So in the non-obese group, there was 70 patients, and weight ranged from 41 to 105 kilos. The obese, slightly 95 patients, and they weight range from 66 to 139. If you look at the BMIs in the non-obese, they went up to 29, so it means included overweight population. In the obese, the median BMI is only about 32, but they did have BMIs up to 49. Ages were pretty well matched, and they did have 2 underweight individuals in the non-obese. They did not actually report treatment-related mortality. The cumulative rate of relapse was not significantly different, even though numerically it's quite different when you look at the obese from the non-obese. Progression-free survival at 1 year was also not significantly different. 68% in non-obese, 86% obese, which is just the opposite of that relapse thing. So relapse was not actually changing their was by the end of the year seemed to have evened out, which is not really clear why. No significant differences in overall survival, time to white cell or platelet engraftment, and rehospitalization rates. T-cell was a higher risk disease for progression, while anybody who had follicular as a baseline lymphoma had no progression at 1 year. And when we looked at other markers for toxicity, mucositis, IV analgesics, non-infectious diarrhea, TPN use, and a cumulative density of bacteremia through day 100, there were no differences in any of these. Equivalent short-term survival with BEAM when you dose on total body weight, whether it's an obese or a non-obese individual. So this is an exploratory study, small n with no power calculation. The obese group was not always truly obese. Some of them, BMI was down as low as 26. The median obese patient was greater than 30, but it's really unclear how many were less than 30 and how many were greater than 40. So it's hard to inform on specific patient groups. The non-obese had more T cell, and that may have affected that relapse-free survival that we were talking about on the prior slide. They also had a worse Karnofsky, and overall, this is a relatively short-term follow-up, but really an interesting paper. So another auto for lymphoma. This a much different regimen. 147 patients between 2003 and 2012, but they're getting an ablative regimen of 1320 centigray of TBI, along with 60 per kilo of cyclophosphamide times 2 doses. They divided into 3 groups: the controls, which were less than 120% ideal; the overweights, which were 120 to 149, and obese in this population was considered 150% or higher of ideal body weight. Those less than 150% ideal body weight were dosed on total body weight, and if you were greater than or equal to 150% ideal, you were dosed on an ABW of 50, so a 50% adjusted ideal. Demographics here, pretty variable age, 19 to as old as 73, which is pretty old actually for that regimen. Median of 57. 12, they did have a median 12 months follow-up from stem cell transplant. A little over half were female. In the obese versus about 30% in the overweight. The controls were 26% female. All other demographics were really similar. You had a median follow-up of 3 years. Actually, and median 12 months to stem cell transplant with 3 year. I think I may have misspoke that earlier, meaning they actually had a 12 months from diagnosis to transplant. So these people relapsed relatively early with their lymphoma. Overall survival at 3 years, the controls 61%, overweight 68%, and the obese at 80%, so slightly better. Cumulative relapse incidence was highest, however, in the control, the overweight, less than the controls, with less and less in the obese. Non-relapse mortality was really the same, so obesity was not increasing the morbidity of the transplant process at 1 year. And male and the non-complete response at the time of transplant were associated with increased mortality. And I think this is pretty well known in the lymphoma population that if you're not in a CR at stem cell transplant, relapse rates are much higher. Weight didn't affect overall survival, and no real difference in chemo-related toxicity between groups. So this is clearly dosing above the ASTCT guideline. We would have dosed on ideal body weight from the guideline. These are autologous patients only, so it's not reflective on an allo regimen. And no difference in regimen-related toxicity. So if you think about it, the dose-limiting toxicity of cyclophosphamide is heart damage. And so they had 5 cases of heart failure. They were pretty evenly spread between the 3 groups. The infection densities, the obese had the least number of infections, interestingly enough, where overweight and controls were similar. No SOS or mucositis greater than grade 1. So really an unclear effect of weight and age as related variables. While there were a lower percent of those elderly in the obese cohort, it's unclear what that meant. The obese weight and BMI are more represented, I think, representative of these populations at 150% ideal, but you're still looking at small n's between the different groups. And I broke that down in the table there. You're looking at 25 versus 29 versus 36. And they did have somebody with a BMI as high as 55. So that's interesting. And we now have kind of case reportish, at least, report on really large people. Another one looking at lymphoma based upon weight. This is adults again. It's a different regimen, busulfan cyclophosphamide etoposide, which is an auto regimen for lymphoma used between 2001 2011. Not sure how widely this is used anymore, but they got 14 doses of busulfan. So this is ablative. Etoposide at 60 per kilo, Cy at 60 per kilo times 2 days. So this is a aggressive regimen. You'd expect high rates of mucositis based on dose-limiting toxicities. And once again, there were no PK. So it's not 16 doses of Bu, but 14 either PO or IV. So while it's not the same as like a Bu-Cy, these are still significant doses. It's dosed on adjusted body weight 25%. If the total was greater than ideal, using defined formula, and they were dosed on total body weight if it was less than ideal. So they had 10 underweight patients, 129 normal BMI, overweight was 168, and then 169 obese. So good mix of patient. Since there were only 10 of the underweights, they were actually added to the normal for purpose of statistical evaluation. So you'll see that it moved from 129 to 139 if you look at the numbers. The underweight and normal were more likely to be female, younger, and a low IPI. This is lymphoma. No significant difference between groups in mucositis, secondary cancers, infections, the time to recovery or length of stay. The 100-day mortality was actually lower in the obese group at 1.8% versus the normal 7.9 and the overweight at 6%. And this was statistically different, but there's no statistical difference in overall survival or relapse incidence at 1, 3, or 5 between groups. So long follow-up here. So it's unclear how this applies to the obese group, given, once again, no BMI breakdown. The busulfan is not getting PK assessment, which is probably against guideline dosing. But the etoposide would have been actually, we would adjust that for mg per kg dosing. So it wasn't completely per 2014 guideline. The psi was definitely above because it's ABW 25 as opposed to ideal body weight. Relatively large patient groups and deeper assessment of toxicity, which it was good information. It certainly adds to the overall data for lymphoma, and we still can't really apply for patients over a BMI of 40. This is a more recent paper looking, and the first one and only one I have actually in reduced intensity, and this is allo transplant, 85 adults treated with a reduced intensity single dose psi at 50 per kg, fludarabine at 150 to 200 per meter squared, and there was variable use of anti-thymocyte globulin, and then a single fraction of TBI at 200 centigrade. Psi is dosed on total body weight unless they were greater than 150% ideal, and then it was on an ABW 50, but once again, this is a single dose of 50 per kilo. The Psi PK were collected, and they were actually looking at the exposure to phosphoramide mustard, which is the alkylating metabolite of cyclophosphamide. They had a previously developed population PK model, and they were going to use that to assess the phosphoramide mustard exposure based on individual parameters. And they came up with 8 different strategies and we're trying to find a best fit simulation to see which was the best way to dose in an obese individual. So if they looked at phosphoramide mustard area under the curves, they actually found that anything that what their surmise was hypothesis was that if as long as they were within 20% in the non-obese to the obese, they're going to be considered equivalent. So, and when you look at the 8 simulations they were run, interestingly enough, BSA dosing had the best correlation between phosphoramide mustard AUC versus a milligram per kilo dosing at ABW 50. A lot of limitations here. This is single dose psi, but once again, it's our only data for allo, and it's a reduced intensity regimen, which we haven't really had anybody look into before. No real clinical correlates. These simulations would need a validation. BMI greater than 35 and greater than 40 are very limited in this sample. And the other work by the author and their group shows that these outcomes would be further affected by fludarabine dose, organ function, patient gender, and they actually have some pharmacogenetic data as well. So while we've been looking at all this as just obese and non-obese, this is I think a good call out that it's not that simple, and that we certainly if there's somebody has impaired organ function, the differences in gender we have not really explored, or pharmacogenetics either. And there's continued emphasis on looking at a lot of these different parameters to see if we can do better than just looking at body weight. So at the end of this, I was asked to do an editorial on this, and currently, as I see it, this is how I would dose cyclophosphamide, because that was where the emphasis of this paper was on. If you're doing the 14.5 mg per kg, whether they're normal to overweight or obese, they really should be dosed. Normal and overweight be dosed on total body weight, but it would not be wrong for anything between ideal and total in the obese individual at the 14.5 per kilo. If you're doing a single reduced intensity, 50 per kilo psi in a reduced intensity regimen, normal and overweight should be getting total body weight, and anything in an obese individual between ideal and ABW 50 appears to be safe and effective. In a 60 per kilo individual, the ideal body weight, or 60 per kilo times 2, ideal body weight would be recommended for anybody normal and overweight. In an allo, we'd also dose on ideal. But given all that auto data that we just wandered through, you could go up to an adjusted body weight 50. In the auto setting, we are doing fully ablative regimens, and this is mostly going to be lymphoma population where your attempt is a cure. We're not doing it in the myelomas. And then if you're, we have not actually looked at any of this, but in the post-transplant size setting where we do 50 per kilo times 2, it should actually be ideal body weight across the board currently. There's no reason to dose higher. And while I don't, it's too early to talk about this, there's an ongoing study called the Optimize trial where they're dosing down to 25 per kilo on ideal body weight, looking to see whether even the 50 is necessary in the PT size setting. So there's no real reason, as far as I can tell at this time, to even think about pushing the dose in the post-transplant size setting. So if we go back to that early thought process, what do you do when you have somebody who has high body weight, high obesity range BMI, and you have unclear data, or you don't like the guideline, or what has come after that? So is it curative intent or not? What's the level of organ function? Normal versus not normal? How high is their comorbidity index? Autologous, where you really need intensity. Allogeneic, where you're looking at immune suppression, depending on the disease type they have, how aggressive it is, and what is the match, as we talked about early on in the kind of the background there. What is the dose-limiting toxicity of the agents involved, and how does that match with the comorbidities of your individual patient? Is there a way we can make the regimen safer? Is there something I can do to dose adjust a single agent, or to otherwise offset it, depending on what the dose limiting toxicity is going to be? What is the disease remission status, a CR versus a PR versus somebody that has active disease? And are they relapsed refractory versus in first remission? And as we think through these process, you're going to go back and forth on what the dosing should be. Bottom line, obese individuals can be transplanted successfully. In the autologous setting, melphalan and etoposide, there's actually very strong support for guideline dosing. And there's some preliminary support suggesting that in autologous, you can dose total body weight up to a BMI of 30. And for a RIC, you can actually do ABW 50 safely, as long as it's not more than 50 per kilo times 1 dose. In the beam setting, you can do total body weight on a BSA up to almost 40. And since this is a curative intent, maybe we should be doing that and not adjusting the carmustine. So that would be a individual call by the center, but it doesn't really change the guideline at this time, and there was no change in overall survival. Additional studies certainly need for prospective assessment by BMI. We need more allo data, and there's growing data for the use of PK and melphalan, and I think that will really potentially solve a lot of the melphalan questions. I would say that guideline, though it was published in 2014, is a starting point, and we're going to consider that from what the intent of dosing is as we choose the different dose parameters. And once again, you want to keep in mind what are the dose limiting toxicities per drug and the maximum tolerated doses. With that, I would open it up for questions. Please put anything you'd like to talk about in the chat, and we'd be happy to go over it with you, explore further.
Fantastic. Thank you so much, Dr. Bubalo. That was great. Really appreciate the review. We do have one question here in the chat. So is there any data that you're aware of on the use of concomitant N-acetylcysteine with cyclophosphamide to reduce any of the side effects? I know this sometimes comes up with busulfan, but are you aware of using that with cyclophosphamide?
None that I'm aware of. As you know, N-acetylcysteine is providing thiol groups, and as a detoxifying intervention, we're kind of doing that for the bladder with mesna, which is one thing at the thiol that's latching onto acrolein and pulling it out. But no, never seen that. Uh, Honestly, I wouldn't know what doses of N-acetylcysteine to choose, and it's not a completely benign intervention as far as taste changes and other things. And then once again, how are we going to administer it, and what would be the proximity to the doses of psi? Um, that sounds like a pilot trial to me.
Yeah, absolutely. Agree. Yeah, I'm also not aware of any great data for using it with cyclophosphamide. Getting a few other questions. What about, are you aware of any data on how to dose treosulfan and whether or not that should be on total body weight or not?
Yeah, when we did the guideline trio was still in early trials. We have been dosing it on actual body weight. We've used a little bit at our institution. It is certainly better tolerated than busulfan. It seems to be similarly effective. As far as I know right now, total body weight dosing is what is called for. It'll be interesting if and when it's approved for general use, and I think it might be getting close. What the product information is going to provide, but right now it's on total body weight.
Yeah, definitely. Great. Thank you. And I think, yeah, with the, hopefully reduced side effect profile, hopefully the total body weight might be safer. So,
Yeah, and
uh,
that'll be interesting to see how that impacts busulfan use. Sorry to interrupt.
yeah, no, absolutely. Agree. And then what about any data that you're aware of for dosing some of the serotherapies like anti-thymocyte globulin in obese patients?
Yeah, there's strong opinion out there that you don't need to dose on total body weight in the larger individual. And you'll see by protocol that there are there'll be adjusted body weights. I don't know that I've seen any on ideal, but it's usually it's usually a 25% adjusted body weight for either the equine or the rabbit monoclonals or polyclonals. And the there's no I've not seen any comparison what that does to change the outcomes. We know that for different regimens, the use of the thymocyte globulins can support engraftment, decrease graft versus host disease, and those are really hard endpoints to compare between populations. So I actually am in the group that my intuition says we don't need in a really large person full doses. And certainly when you think about infusion reactions and some of the other events that are going to occur as we put really large doses into people, there's an increased risk for toxicity. So I really support the ideal, but there aren't evidence or I mean the adjusted ideal body weight for dosing. But the best data actually I think are coming out of the Netherlands, where they have looked at actually PK of these different antibodies. And I would encourage you to look at that data because they do end up dosing down in most individuals.
Yeah, I agree. I think that's a really interesting area of study, the PK based and the absolute lymphocyte count based dosing, which seems to potentially be more appropriate. And I think, something that even comes up in some of those publications that I've seen is, depending on what you're targeting and what you're using your ATG kind of primarily for, should you even be using the weight of the patient versus the weight of the donor, or the ALC of the donor? So those are also some interesting things that kind of come up in that discussion too.
Yeah, and then the other thing that's challenging a lot of this is the move towards the post-transplant cyclophosphamide, which has been uniquely successful in a lot of different graft sources. And whether or not some of these other things are going to continue to be explored, or are we going to, and at some point, find a patient or graft population that breaks out of the PT-Psi as needing additional or immune suppression and starting adding these things into PT-Psi. The one thing I am concerned about is I've seen um, some clinicians who want to give Psi in the prep regimen and then give PT-Psi after, and I would be very concerned about exceeding a 200 milligram per kilo dose anywhere in that, because we know that you're really bumping up against significant cardiotoxicity and the risk for heart failure.
Yeah, absolutely agree with that for sure. And then one other question I have that's kind of adjacent to, a lot of this discussion is, are you aware of any data or recommendations for Cytoxin dosing for CAR T cell lymphodepleting regimens and what the preferred option is there?
So it depends. So in the approved setting of the current CAR T products, most of them are somewhere between 250 and 500 milligram per meter squared, and that is all based on total body weight uh, calculated BSA. In the products that are coming up in uh, the lifileucel and some of these others, where we are going to give ablative regimens of busulfan or busulfan plus cyclophosphamide, because there's a bunch of in study solid tumor CAR T products which may or may not make it to market, but they will get a full BuSci prep sometimes. And those I think we should dose the same as a stem cell transplant prep, giving the per study until we know otherwise, because they're looking at not so much that they're trying to ablate, but they're trying to do a total lymphocyte depletion. And I've read some of these protocols. I review them for our IRB, and they are it's based really on transplant evidence and not CAR T evidence. So we this will be something as a cellular therapy pharmacist, you're still going to be employed in the future. There's still a lot
Yeah,
going on. Sorry about that,
absolutely.
Paul.
Oh, no, that's okay. Yeah, absolutely. And I get surprised sometimes on some of the clinical trials, not even in just, cellular therapy or CAR T, but, even in some of the transplant clinical trials, how often they just defer to institutional practice or institutional standards for dosing weight. So that really leaves, I think, sometimes a lot of questions on what's the most appropriate. So I think it would be great if some more of these trials would be more specific on what they recommend or prefer.
Yeah, or at least say per guideline, since there is a guideline out there. But and given the variability between both U.S. institutions and that paper with the European institutions, they're get that is a very mixed experience, and I hope they realize that when they look at their data.
Yeah, absolutely. All right. Well, I think that brings us to time, and we've answered all of the questions that I can see. So, very much appreciate your time and expertise. This was a fantastic presentation, and thank you to everyone for attending.
Have a good day. Thanks
You
for
too.
joining us.